I'm happy to welcome Dr. Eran Horovitz, who will chair the panel. Eran is a specialist in obstetrics and gynecology and has been a senior physician in the IVF unit of the Department of Obstetrics. You made it on purpose with these words. Obstetrics and Gynecology at Wolfson Medical Center since 2007. He is a fertility physician and the director of the Women's Health Center of Maccabi Health Services in Ashdod, as well as a lecturer at the Sackler Faculty of Medicine of Tel Aviv University. Eran.
Good morning. Thank you for the introduction, Orit. Our session is going to be about the interface between medical and psychosocial implication of ART. The first speaker is a colleague and a friend of mine, Dr. Avi Tsafrir. He's a senior IVF physician in Shaarei Tzedek Medical Center in Jerusalem and coordinates all fertility preservation activity in this center. Avi authored and co-authored over 30 medical and scientific articles in peer-reviewed journals and his lecture in the Hebrew University, Jerusalem. His research is in the field of infertility with emphasis on advanced age patient fertility preservation and decision-making in medicine of both patient and healthcare professionals. Dr. Tsafrir today is titled, "I Don't Believe in Statistics. Why Do Women Keep Choosing Ineffective Fertility Treatment?" This subject is a very interesting subject, I think, especially in Israel, and I'm sure we will speak about it because of what the lectures before talked about the patient to be a parent in Israel, and many people who don't become a parent feels guilt and incomplete. So, please.
Okay, thank you, Eran. Thank you for I would like to thank the organizers for the opportunity to speak in this special meeting. I'm an IVF clinician. I really like what I do. I feel lucky to do what I do. But we know that sometimes what we do is simply doesn't work. So now, thanks to the work of Professor Lerner Geva, who is here, and our colleagues, we have Israeli national data. And we can see that about a third of IVF treatments in Israel is performed on women age 40 and older, and 1 in 8 cycles is on women age 43 and older. This is a higher portion than in other countries, but the fertility treatments in older women occur everywhere. And what are the results of this most sophisticated medical intervention? We can see that after age 43, the chance to have a live birth after embryo transfer is less than 4%. Note that in about half of these cases, there were no embryos to transfer to begin with. So it's much lower for the woman who starts treatment. As one of the critiques wrote, when 96% failure become a success. So this might improve with repeated treatments. This is what we call today cumulative delivery rates. And indeed, according to UK data shown here, the chances for delivery after a delivery after 6 cycles, if the woman is younger than 40, would be 70%, and a little above 30 at age 40 to 42. What happens with older women? We don't exactly know, since in the entire UK, for example, in a period of 10 years, only 67 patients had 5 cycles after age 42. In Israel, it's what we do in one unit in about 2 years or so. But as far as we can tell, the chances are very low. So this is the question: why do some women repeatedly choose to undergo fertility treatments when the chances are so poor? Well, obviously they want children, and they want the children from their own oocytes. But when this is still unlikely to happen, what is the decision-making process that they make to still make ineffective choice? So is this because they don't receive proper information about their chances? This is a claim, for example, the Israeli press often makes without real data to support it. It's about not understanding the data. or the more complex psychological mechanisms. So we aim to look at this in our study. It was a simple study. We distributed questionnaires to women undergoing fertility treatments at age 43 to 45 using their own oocytes. At any stage, at any kind, with any kind of fertility treatment. The study was conducted at 3 public IVF units and 6 outpatient fertility clinics, most of them in the Jerusalem area. The study was supported by a research grant from the Israel National Institute for Health Policy Research on a topic defined in Hebrew as futile medical activity. So here are the results. There were 93 women who responded. Some description, about half of them were single, about half had children when participating in the study. Religiously, third defined themselves as secular, third is Masortit, which is somewhat religiously affiliated, and the third is Orthodox. 90% had academic or vocational education. Half were married or had a partner, half planned to use donor sperm. And clinically, these were not beginners. 80% of them had fertility treatments before joining the study, mainly IVF. And of those who had IVF, the mean number of previous cycles was 4.7, and the range was 1 to 17 cycles. So you can guess the prognosis. A third of them already had a child as a result of fertility treatments. And I would like to start, let's dispel one myth to begin with. Fertility treatments in Israel are free. Officially, that's true. Treatments including IVF are covered until the birth of 2 children up to age 45. However, some aspects are not for free. Donor sperm samples, partial cost of medication, complementary medicine, private consultation, egg freezing, etc. When we ask women about what they spent out of the pocket, the mean amount was 23,600 shekels, with a wide range. Now that's about 3 times the median monthly income of women, sadly, in Israel. So while the cost for the patients is much less than in many other countries, significant amounts are still spent out of pocket. It's not completely free. And now to our main study question. And the question was very simple. What do you think the chances are your next cycle will end in a delivery? Now, in reality, we can generously assume about 5%. Practically, I think it's 1 to 2%. And the cumulative rate, we don't exactly know, definitely not higher than 15%. But what our respondents thought was 48%. And if we ask them about what will happen after repeated cycles, it rose to 60%. 1 in 3 women thinks that she has 80% to have a child as a result of treatments. And only 1 in 5 is somewhere in the area of reality. So we have an answer to our study question. Women continue treatments because they think their chances are very high. And that makes sense. The next step was to try to find out how were these conclusions reached. Did they not receive information or receive misleading information? So we asked them, what did your providers tell you? And about 3/4 reported that they did receive either verbal or numerical quantitative information. And only 1 in 4 claimed they received no information or did not respond to this question. And how were these predictions put in words? So I will show you some quotation from questionnaires. And reading them, I think you may almost feel doctors trying to struggle between a way to be honest and to tell the truth and be informative, and while not completely losing hope on the other hand. Personally, I like this one, these chances and others. And I think not very high is also an interesting way to describe 95 chance to fail. We tried subjectively to classify numerical and verbal descriptions to very, very low, something a little less pessimistic, and relatively more optimistic, such as medium chance. We weren't able to classify all of the medical descriptions, but we can see that according to patient testimonies, most patients did receive estimation and most receive accurate, poor predictions. Does it make any difference? Does it change the plan? So we asked if there's a certain cutoff value of estimation of success below one would not even bother to try. And the answer is definitely not. 80% said they would attempt treatments regardless of any a priori estimation. I think this response reflects well the attitude and also gave us a title for the study, and note the joy of the respondent here. We all agree that patient decision-making should be based after all relevant information was given. This is a major principle, both ethically and legally, in medicine today. But do patients really want to know everything? When we asked about their preferences in this manner, when the chances are very low, 30% would rather receive such information only when they directly ask about it. So don't tell me everything, even in a hypothetical scenario. So they told me my chances are very low, but that's in general. What about me in person? Maybe I am different. So we asked, what do you think your own chances are compared with women at the same age? Are they better? Are they a little worse? Much worse? And these are the results. This is very human, I think. There is a strong tendency of patients to feel that their own chances were better than the average, or in other words, better than what their doctors predict. And what makes them feel this way? So here again, quotations, various reasons, starts from the number of the hormonal tests and number of oocytes, through the attending physician, nutrition, faith, homeopathy, and ending with their grandmother's obstetrical history. I can tell you, in fact, that none of these really make a difference in their prognosis. What are the plans? What are the future plans? Is there a limit on the number of cycles or money? And most women do not set a limit, or more often, and that's important, do not know. What about alternatives? In Israel, adoption is very problematic, so the clinical alternative is egg donation. Now, is it important for patients that the egg would be of their own? Very much, very important. 90% responded so. But when we asked about the chance they will use this option in case there is no other way, 1/3 said it's not an option. And most women said there is some chance they would do it, or again, did not know. We did, however, find gaps in knowledge about egg donation. Only 30% accurately knew what success rates were. 30% did not know this option is even available in Israel, and half had no idea about the cost. Whether they didn't know or didn't want to know, we didn't ask. So what's going on here? The main finding is that women facing very poor prognosis, here we looked at advanced age, but there are other clinical groups as well, have unrealistic expectations. They actually ignore reality. They ignore objective prediction. And they do so despite being informed, according to their own testimony. At least one mechanism that may explain this would be a personal tendency to believe their own prognosis is better than others in similar condition. And many times there is no plan and no serious consideration of alternatives. So a rational decision-making process does not really occur here. Now, some thoughts about how to explain this from a psychological point of view. So first is the optimism bias. Most of us are unrealistically over-optimistic about ourselves, about the future, and our ability to control it. Secondly, there is the better than average effect. This means that people tend to evaluate themselves as better than the average peer on most positive traits. There are many examples for that. I think this is a wonderful one. This is where researchers looked at an a priori group which is lower than the average, and they interviewed prisoners who were jailed for violence and robbery and so on. And they asked them about how they feel about themselves in pro-social characteristics compared with other prisoners and with people in the community. So even prisoners believe themselves to be more pro-socials in kindness, morality, self-control, and generosity than non-prisoners. And they rate themselves equal in obeying the law than non-prisoners, even though they were in prisons and the others were not yet. So, and the third possible explanation is that we tend to overestimate small probabilities. We're not good at small probabilities, and stories, words, are much more powerful to us. For example, when this patient tells us she had a relative who gave birth at 48, and such rare things do happen sometimes, this seems to be more powerful, more tangible than the 2% probability the doctor gives you in general. So what can we do as professionals? So some thoughts. Technically, it's better to refrain from inaccurate verbal terms. For example, low chance. What is low chance? What does somebody understand from the word low chance? Is it 3% or 30%? 30% is also low when you think about a child. It's better to use frequencies, such as in your age, 1 in 8 women will have a child. Behaviorally, we think teams should encourage setting a stopping rule. Now, what happens today in Israel that when money stops at age 45, most people stop treatments, although money itself is not the key issue, as we have shown. So they actually adopt an external stopping rule somebody set many years ago at 45. So we think that if you set yourself, let's say I will stop treatment at 43 or after 3 cycles or at the summer, this may be useful to stopping all this inefficient work going on. What do doctors think? So I think most of us think of something like that. I really explained the situation accurately. I recommended to stop. And she understands, but she still wants to keep trying. It's her right. What can I do now about it? And I think the real mission for us as caretakers is much more difficult than planning another futile cycles or changing medication. It's to really help coping, as Professor Peterson said, with this tragic loss of the wish for parenthood, at least genetic parenthood. And providing information is not enough and is not the key issue. And I think the involvement of counselors and therapists is crucial in this manner. Finally, that's it. I would like to thank my colleague, Professor Talia Miron-Schatz. She's a psychologist. We did this study together, my collaborators, and especially the research assistants who had to spread this simple but direct questionnaires, and it was not always easy. Thank you for listening.